this session of glaucoma, innovations and my experience. Now I request the keynote address by Dr. G.R. Reddy Garu, who is a stalwart and doyen in ophthalmology, to give his talk on structural and functional correlation of retinal ganglion cells in glaucoma.
Good morning, everyone. As expected, I know that only at this time, only the speakers will be there. So we can learn from among ourselves. And today I will be talking about the function structure correlation of retinal ganglion cell in glaucoma. Actually, what happened, just like visual fields, without proper understanding of visual fields way back, 20 years back, people started interpreting the fields. Now only just OCT also without proper understanding, because there are no proper books also, and exactly we do not know how to interpret OCT, and because there are a number of false positives, and there is no proper book, and we have to learn by our experience. So with all my experience of OCT for the last 7 years, I made my own presentation, and this is you don't find a presentation like this. This is purely on my own experience. You don't find in any book. And so far you might not have this type of lecture from any YouTube downloads. The most important part in glaucoma is the always evaluation of the disc. So if you don't have the correct concept of evaluating the disc, and you don't come across to the need for asking for OCT. So my plan of the talk is, first I will talk about the topographic correlation of the RNFL and the visual field areas, and the thickness values of the ganglion cell at the macula and RNFL at the calculating circle with p-value color code. And what is the role of OCT, just like visual fields? What is the role of OCT in advanced glaucoma? What is the role in established place of glaucoma? What is the role in OCT in the diagnosis or glaucoma suspect? The most important thing is topographic correlation. If you see, we know that the macular fibers, suppose this is the left eye. The macular fibers, we know that it will be entering here. And the temporal fibers nearer to the fovea, they don't enter here. The most important part is they enter at the left eye at the 5 o'clock position. That is important, and these fibers also will enter in this area. Therefore, this is a highly crowded area, and this is known as the macular vulnerable zone. That is why you will get more upper arcade scotomas when compared to lower arcade scotomas. In addition, the fovea is placed on a lower side, therefore more crowded fibers will be there occupying, and the upper fibers have more space to enter. Now we know this is the 6 o'clock, it corresponds to the peripheral fibers. And as I already told, the temporal fibers of the macula nearer to the fovea, they will be entering here, the macular papillary bundle height. And if you see the p-value, the red appears when the thickness of both the quadrants, these quadrants around 80 microns, the red appears. And more than 80, actually you can forget about the yellow, because yellow got very, very narrow range. The p-value 1% to 5%. So there is a lot of overlapping of yellow with red and yellow with green. Don't give much value to the yellow. There are only two, green and red. And there are a lot of overlapping on the yellow. And the normal values, if RNFL, you see it is 133, 107, and on the either side is the nasal. This is the nasal around 60, and this is actually around temporal around 40, 62, 62. They are all. And this lower will be higher. But when it reaches 80, in the lower and upper, the red appears. And when it reaches the temporal, these fibers, around 45, the red appears. It is around 35, the red appears. So we should know when the p-value, that means the p-value less than 1%, just like visual fields. This is a very important thing you should remember always. Whereas in macula, ganglion cell thickness, if you see the ganglion cell thickness, it measures 5 degrees on vertically and 7 degrees horizontally. That is the area the ganglion cell thickness will be measured. And around 90, usually 95, more than 95 white will be there. And up to 75, you can take for example 75, still it is green. And between 75 to 70, it is yellow. Almost from 68, the red appears. The p-value less than 1%. So normally there is a lot of buffer, because even the ganglion cell thickness normally is 4 lakhs to 12 lakhs. So sometimes in a patient there may be 80, there may be 75, and there may be 100. So we do not know exactly what is the macular thickness of the patient. Now, in advanced case of glaucoma, you take for example, the last to go is the macular papillary bundle. We see the lower temporal field is retained. The lower temporal field means it is not the nasal fibers. It is the temporal, it is the macular papillary bundle. That is not the nasal fibers of the retina. It is actually the nasal quadrant part of the macular papillary bundle. And surprisingly, if you see, in the advanced case of glaucomas, the RNFL thickness in the nasal quadrant is almost normal. That means the nasal fibers are not visually important. See, you take all advanced cases of glaucoma, you study RNFL, they will be green. So the last to go is the macular papillary bundle. And so you see the macular papillary bundle, even 47, 48, it got good retinal sensitivity. 48 at the macula. But originally the red started at 68. So just like a black square in the fields, it doesn't mean that it is absolute scotoma. Minus 10 is also black square, minus 15 is also black square, minus 20 is also black square. Like that, the 68, the retinal sensitivity will be very good. 60, it will be very good. Up to 55, you may have the relative scotomas. When it goes below 50, then it will become absolute. See, 47, still minus 7, it got good retinal sensitivity. When it is 43, absolute. See, 55, 55, 55. Here, see, they got 14, 15, less than 8. If it is. Take for example, now what is the importance of OCT in advanced case of glaucoma? You take these fields, you want to go for surgery or you want to go for medical management. This is actually 72. So it got a huge buffer effect. Even if you go for surgery, the wipe off will not be there. So it helps us, and both are looking similar. And this patient actually requires more aggressive treatment. It almost reached 62, 51 when compared to 72. So it helps us to moderate our treatment. Now, what is the role of OCT in established case of glaucoma? Take for example, this is the two patients. As a fieldsman, we concentrate on the field defect. What is the depth of the field defect? What is the location, extent, and direction of progression as a fieldsman? But as an OCT person, we concentrate on these areas. Then actually I introduced a new terminology in this case. I call this part as the pre-perimetric part of perimetric glaucoma. It is a pre-perimetric part of perimetric glaucoma. So I want to see what are the ganglion cell thickness of this. If you see, the ganglion cell thickness is 76, 91, 102. And here it is 55, 55, 55. You see, the 55, 55 is also normal 10-2, confined to this area. So this patient requires more aggressive treatment, and this patient may require only one drug. This patient requires 2 drugs. So OCT not only for diagnosis, it helps us to moderate and our the treatment part. Take for example this case, 78, and this is all because the upper part is already gone. This patient is having good retinal ganglion cell thickness. No, you can tell that you are safe, your ganglion cell thickness is very good, and you need not go for 2 drugs or 3 drugs. Single drug may be enough. And here also 80, 79, 70, here 68, 71. So you have to assess what is depending on this thickness, how often you require the fields to be repeated, and telling the prognosis, and to go for surgery. All the ganglion cell thickness will help us. See, this patient is more dangerous than what we have seen previously. This almost 67, 68, 73. This patient actually requires more aggressive treatment than these cases. But you see, this appears to be less affected. So the OCT plays a major role for take for example this case, 54, 54, 61, and in no time. So what we called previously glaucomas fast progressive and slow progressive. It is not like fast progressive and slow progressive, because at that time we do not know what is the GCA thickness in that patient. If you know the GCA thickness in any patient, then we can tell that that patient is fast progressive if you don't go for the target pressure very low levels, or you go for surgery. Now we understood what is the role of OCT in established case of glaucomas. Then what is the role of OCT in early glaucomas or glaucoma suspect? Actually, this patient glaucoma suspected on the basis of IOP. The fundus looks normal, and almost visual fields normal, even RNFL is normal. And here, the ganglion thickness started 67. So 67, you don't get any expect. When I talked in the GCI, I talked indications of 10-2. Now I tell you, when you need not do 10-2, when the GCA thickness is more than 60, you need not do 10-2, because even if you do 10-2, it will come normal. See the same on the other eye, left eye, you see the thickness. And this is another patient, glaucoma suspected actually on the basis of the disc. And see, and this is normal, but when the purely macula, the glaucoma, because I made my own classification, glaucoma starting within 10 degrees, glaucoma starting outside 10 degrees, and glaucoma starting simultaneously within and outside. And this is purely glaucoma starting within 10 degrees, and it is hardly very difficult to suspect glaucoma from the disc. And if you very carefully, if you see, you may appreciate a notch. So if the glaucoma starts within 10 degrees, you appear first notch. Here I suspected notch here and corresponding to this area. And water drinking test I did, it came positive. Same, glaucoma started within 10 degrees, within no RNFL. And here you see there is a suspicion. This patient, because this is the overlap provision is there. This is the ganglion deviation map of ganglion cell GCA analysis, and the deviation map of RNFL. And if you can overlap it, this patient, I strongly suspected, it took me for 1 year to start the treatment in this patient. The pressures are almost normal, but there is a strong suspicion for me the notch. So glaucoma starting within 10 days, only if you carefully observe the notch you may appreciate. And this normal, almost normal. And if you see the overlap, the span map analysis, and you can see beautifully the arcade. And this is the, and we can tell to the patient, and it appears, I started the treatment. For that, actually, it took 1 year to start the treatment. This is another case, within 10 degrees, almost feels normal, OCT normal. Here, there is a suspicion, and this corresponded to ganglion cell thickness. The other eye. This patient also, almost looking normal, and the GCA, because there is no RNFL thinning, only macula. So you may not, but in this patient actually I appreciated this RNFL defect in this patient. If you carefully observe, see, if you carefully observe, you may find. This patient, almost, they're all pressures almost normal. Only this here you can see some disc suspicion is there. And see the levels here in this patient, even though they are normal, once it reached 46, 59 and 79, 68. Here, because it is 46, 59, you see it appeared in the visual field. And this is also seen in the visual field 24-2 and the 10-2, because this 46, the upper part is okay. You can see how beautifully when you overlap the deviation maps of ganglion cell thickness and the deviation map of RNFL, it came normal. So, thank you. So this is the value we have to, because the only problem with OCT is identification of false positives. You must have very thorough knowledge of OCT, otherwise you are likely to over-treat or under-treat. So most important thing is correct, the understanding of OCT printouts is very, very important. Thank you.
So I thank the chairperson of this session, Dr. G.R. Reddy Garu, for his enlightening talk and for using the new words like pre-perimetric area in perimetric glaucoma with nice pics. Thank you so much, sir. Let us move on to the next talk. Actually, next speaker is not available. That's why we will move on to the next speaker. Dr. Himabindu will be delivering her talk on medical management of glaucoma.
Good morning, everyone. So I'll be talking about medical management of glaucoma. We all know that glaucoma is a progressive optic neuropathy, and we are all aware that whatever damage occurs in glaucoma is irreversible. So when we are treating a patient, what we are trying to do is we are trying to preserve whatever healthy nerve fibers are left so that we can preserve the visual function and delay the disease progression. All this by maintaining the quality of life of the patient. So how do we do that? We do that by reducing the intraocular pressure. Intraocular pressure is the only risk factor whose manipulation has shown to alter the glaucoma progression. So that is the only thing we can aim at. So when we see a patient, we look at what is the initial pressures, initial presenting pressures of the patient, what is the extent of disease in the eye, how much damage is there, what are the comorbidities, is there a strong family history. So depending on all these factors, we arrive at what is called target intraocular pressure. So to achieve the target intraocular pressure, we either give them medical management, surgical treatment, or laser treatments. So intraocular pressure is elevated basically because of reduced aqueous outflow due to functional or structural abnormalities. So when we are treating glaucoma, we treat the mechanism. That is, we remove the precipitating factors. If there are any factors which are causing raised intraocular pressure, try to, withdraw that. Reduce the intraocular pressure, correct the abnormal anatomy. If there is secondary glaucoma, then you treat the underlying pathology. And if there are any associated systemic problems, you can consider treating them as well. And medical treatment is very effective in majority of the patients, and it is widely available. We have an armamentarium of anti-glaucoma medications, which are quite effective and patient-friendly nowadays. Only thing we have to remember is it requires good compliance from the side of the patient and his family. And the choice of medicine, as I told you, depends on mechanism of glaucoma, comorbidities, and risk factors. When I see a patient with angle closure glaucoma, what I do is I do a AIOCMTC2 and then treat in the lines of primary open angle glaucoma itself. So we have all these kinds of medications which are available in the market now: prostaglandin analogs, beta blockers, alpha agonists, carbonic anhydrase inhibitors, cholinergics, hyperosmotic agents, and most importantly, fixed drug combinations. After the advent of fixed drug combinations, it has become very easy for the patient to administer them, and even for the ophthalmologist to prescribe medication, more of adherence to the medication is there after fixed drug combination has come in. Although there are, some people think that when you have a fixed drug, maybe the drugs may not act as well as they are given individually. But that's okay, because the number of instillations comes down, adherence increases, and even exposure to the preservative also decreases with the less number of drops. So I kind of like fixed drug combinations. So how do these medications actually work in glaucoma? They either increase the aqueous outflow or they decrease the aqueous production. So it all started with beta blockers and myotics. In my undergraduation and early post-graduation, this was what I have seen many doctors prescribe: beta blockers, timolol, and myotics, pilocarpine. So beta blockers were good because they were giving around 20-25% reduction in intraocular pressure with a dosage of 2 times a day. It was convenient for the patient. It was economic for the patient. Coming to the myotics, that is also a good drug. It actually causes constriction of the pupil. It stretches the iris and increases the trabecular meshwork spaces, thereby increasing the aqueous outflow. But the problem with the myotics was the dosage was 3 to 4 times in a day. And then because of meiosis, if the patient had developed cataract, there was early visual dampening, and it was difficult for the patient also to do surgery in myotic pupils. And there was brow ache, and also beta blockers was a better medication at that time. Beta blockers, even now nowadays also we use in the treatment. Pilocarpine, though it is used only in particular conditions like plateau iris syndrome, or where you have given maximum medical therapy and you still want some more reduction, you can't go in for a surgery, then you can try pilocarpine. And to do AIOCMTC2, definitely we use pilocarpine. Then came in adrenergic agonists and carbonic anhydrase inhibitors. So they were introduced as second line of medication, and the dosage was 3 times in a day. They were giving around 15 to 20% reduction in intraocular pressure. So they were good when given in with beta blockers. So that went on for some time. Then came the prostaglandins. Prostaglandins were definitely wonder drugs because their pressure reduction was almost 30 to 35%. So I was first introduced to a molecule called latoprost. Latoprost was bringing down the pressure very well, but the problem was it was pretty expensive for those times. Even if they had an offer like 1+1 offer, still at those times it was considered expensive, and it needed a cold chain to maintain. So it did not probably become that popular. Then came in the bimetoprost, which was good, which was very effectively reducing the intraocular pressure, but the problem was a lot of ocular side effects. A lot of hyperemia, eyelid pigmentation, eyelash growth and all. Patients were finding it very difficult to accept the drug, and even as ophthalmologists, we were finding it difficult to give that. That was when it was 0.03%. Then around 2006 or so, travoprost came in. And travoprost was very good. It was my first line of, first choice for a long time, because it was bringing down the pressure well with only 1 instillation during the night time, and not much ocular side effects. And they came in with what was called endurance. So the patient was, even if the patient has little difficulty in administering the drop at the same time, still the IOP was maintained. There was no peak and troughs. So as I was telling, the side effects, I will not tell much about it. One thing what I want to tell is, when you see a patient, when you initially see a patient, depending on the intraocular pressure and depending on the target IOP that you have decided, what you should do is you should prescribe one medication which has the greatest chance of reaching the target pressure, with best safety and tolerability profile, minimum inconvenience, which is affordable, and maximal likelihood of adherence. So minimal concentration and minimal frequency. Start with that. So once you have given a drug, call back the patient after a week or 10 days and see if the IOP reduction is according to what you have thought. You know the prostaglandins bring down the pressure by 30%. So if the pressure reduction is according to what we expect, but still it has not reached the target pressure, then you can add one more drug. But if the pressure reduction is not as much as you expected out of the drug, then you switch to another drug rather than going on adding medication. You can even switch to a different prostaglandin. Sometimes that prostaglandin might not work. Some other prostaglandin might work for that patient. Still it is not coming, then you can add one more medication. Do not combine two drugs with same pharmacological actions. Do not use two fixed drug combinations with overlapping categories. Sometimes when the initial pressure is very high, that is above 40, then you can start them on more than one medication initially itself. So you have to make sure that the patient is compliant. Talk to the patient and the family members, explain to them the prognosis of the disease and importance of using medication. You can ask them to, keep some reminder systems, like in the mobile they can have an alarm or so. My time is over, I guess, sorry. About the newer drugs, Shailaja will be speaking. Just want to summarize by telling that prostaglandin analogs are the first line of therapy, followed by beta blockers and POAG. Alpha agonists and CIA inhibitors are the second line of therapy. Neuroprotective agents are still under trial, and there are newer drug delivery systems to enhance the adherence and ease of instilling the medication. Thank you very much.
Thank you, Dr. Himabindu, for using nice captions also, like start low and slow, and about the reminder systems. Now I request the next speaker, Dr. Shailaja, to talk about newer drugs in glaucoma.
So, good morning everyone, I am Dr. Shailaja. So, actually my presentation is a bit lengthy, but I will try to cut short and skip few of the slides. So, why is there a need for newer drugs when we have so many drugs already in glaucoma? Can I have a pointer, please? Pointer. So the medication that are available at present, they focus mainly on increasing the uveoscleral outflow and decreasing the aqueous production. But 80% of the outflow, which is the trabecular meshwork outflow, is yet unanswered. So the newer drugs target mainly on the trabecular meshwork outflow. So these are few of the newer drugs which help in ocular hypotensive, stem cell therapy, neuroprotection and gene therapy. So they can be divided in those things. So newer ocular hypotensive agents are the ROCK inhibitors, alpha-1 receptor agonists, nitric oxide donors and cannabinoids. So these are the Rho and Rho kinase inhibitors. These belong to the Rho family, and they phosphorylate many downstream target proteins. So the mechanism of action is that at the end they increase the aqueous humor outflow resistance, decrease the aqueous outflow resistance. So role in decreasing the aqueous humor outflow resistance is by the increase the number of Schlemm's canal and endothelial pores, and hence decrease the focal adhesions between the Schlemm's canal cells and the juxtacanalicular tissue, and relaxes the smooth muscle cells in the trabecular meshwork. This in turn increases the blood flow to the optic nerve. Other actions are like they increase blood flow to the optic nerve head, promote ganglion cell regeneration and regulate the scar tissue. Excuse me, sorry. It's okay, ma'am. Thank you. Sorry for that. So the ROCK inhibitors that are available in market present are the netosudil and the ripasudil. So Reiki is no financial interest. So Reiki is the netosudil eye drops. It's applied once daily. So additional advantages of this is that they decrease the aqueous humor production and also supplied in combination with the latanoprost in the trade name of Rocklatan. So these are few of the studies which I am not going into details. So what they does is, like when applied on the cornea, in the presence of corneal esterase, it gets converted into nesartudil M. And this is the ripasudil. It's available as 0.4%. It is a derivative of fasudil. The regimen is twice daily. So additive lowering, IOP lowering effect of ripasudil with timolol and latanoprost has been noticed. These are few of the side effects of the ROCK inhibitors like conjunctival congestion, subconjunctival hemorrhage, and corneal verticillata. And all these adverse effects reverse after cessation of the medications. So these are the drug trials, which I am not going into details. These are the adenosine A1 receptor agonists. So they are located, the receptors are located on the trabecular meshwork and the ciliary body. In the trabecular meshwork, they upregulate and it increases the outflow facility, and in the ciliary body, upregulation causes reduced aqueous production and decreasing the intraocular pressure. This is again the mechanism of action. So BCKA channel modulators are the nitric oxide donors. So dysregulation, normally the nitric oxide synthase is decreased in the trabecular meshwork, Schlems canal and ciliary muscle in patients with POHE. So dysregulation of nitric oxide generation contribute to the elevation of intraocular pressure. So what they does is these donors, they provide nitric oxide, which causes trabecular meshwork and the Schlems canal cell membrane hyperpolarization, as you can see here. Hyperpolarization, decreased calcium influx, they inhibit the actin and myosin interaction and relaxation of the trabecular meshwork and the Schlems canal and increased outflow facility. So nitric oxide donors approved are the nipradilol and latanoprostene bunode. So this is the nipradilol is the twice daily dosing. Latanoprostene bunode, when applied, it gets so on application to the eye, in presence of corneal esterate, it gets divided into latanoprostic acid and butanediol. So latanoprostic acid acts similar to the latanoprost, increases the US scleral outflow, whereas butanediol monotritiate, it gives active metabolite nitric oxide. This is the nitric oxide donor. These are few of the studies. So nitric oxide, it is both a neuroprotective and a neurodegenerative agent. So coming to cannabinoids. So despite extensive research, the role of cannabinoids in medical management still remains limited. So I'm not going into detail. These are few of the neuroocular hypertensive medication under evaluation. So steroid antagonists, siRNAs, we call it as S-Silk, lateralclanic acid and the K-ATP activators. So still I'm not going into details of these things. So neuroprotection, the process of glaucomatous cell death always is due to apoptosis. So blocking the apoptosis increases the cell survival. So causes of, these are few of the causes of, retinal ganglion cell death. We call it as small mnemonic as skin. So one is the induction of superoxide, K is induction of kinases, I is increased intracellular calcium, N is neurotrophin deprivation, and E is excitotoxicity. So these are few of the methods of neuroprotection, pharmacological, again we can give a mnemonic as PIPs, pharmacological, immune modulation, preconditioning and stem cells. So pharmacological, we have the memantine, glutamate receptor antagonist called memantine. This prevents calcium influx in the retinal ganglion cell and subsequent apoptosis. So brimonidine, it causes upregulation of the anti-apoptotic factors and inhibition of nitric oxide synthase. These are few of the neurotrophins like brain-derived neurotrophin, ciliary neurotrophin factor, and the growth-derived like nerve growth factor. They are still in the trials. So immune modulation is one of the newer techniques still under trials. Focal activation of the immune system in the optic nerve or the retina. This activates the T lymphocytes primed to the optic nerve and constitutes and releases the neuroprotective factors. So preconditioning. What is preconditioning? So preconditioning is causing a sublethal injury which subsequently protects the more severe glaucomatous damage. See here we are preconditioning it with a sublethal injury and tolerance is attained here, and when there is a severe injury it gives neuroprotection. So the major trials that are going on now are the stem cells. They can be used for repopulating the retinal neurons that are lost in the glaucoma. So stem cells are mainly extracted from the hair, bone marrow, adipose tissue, and the dental pulp. These are the mesenchymal stem cells, as you can see here. So they are neuroprotection, retinal activation, and produce the all GDNF, BDNF, and CTNF, which helps in neuroprotection. So gene therapy, this is the latest thing that is good. Aquaporin and brain-derived neurotropic factors have been being tried now. In a nutshell, these medications, the newer medications, they help in increasing the trabecular meshwork outflow, the uveous scleral outflow, and the aqueous humor production. These are a few slides on the drug delivery systems. So the common complaint of difficulty in instilling the drops and difficulty in adhering the eye drops administration schedules. These are the common complaints that the patient gives us. To erase the chronic medication use, new sustained delivery drug delivery systems have been developed. So one of them is the OcuSert. This was first sustained pilocarpine implant that is introduced in 1975, but this was soon taken off because of the poor medication tolerability. Next is the bimetoprost implant, also called Durista. This is a sustained release biodegradable implant that uses the Novadur drug. This is the drug delivery system that has been used, the Novadur drug delivery. The implant is administered into the anterior chamber using a 28 gauge single use pre-filled applicator. The drug delivery system is made of the biodegradable polymers which disintegrate by hydrolysis into carbon dioxide and water. These are few of the trials of the Durista. So main concern with this delivery system was the drop in the corneal endothelial cell density, which was greater than 20% at 20 months and 20.8% respectively after 10 and 15 microgram groups when divided into these two groups. This is the bimetoprost ring. So this is a polypropylene ring that is impregnated with bimetoprost. It continuously elutes bimetoprost for a period of 6 months, after which it needs to be replaced. But the rate of drug elution decreases over a period of time. That is the main drawback of this ring. So contact lenses, these are use of missile-laden contact lenses for delivery of the glaucoma medications. Advantages are the patient familiarity and long hours of use. Travoplast punctal plugs. So they are inserted into the upper or the lower punctum. The delivery of travoplast was over 90 days. Sir, almost done. Almost done.
Please stick to the time, no?
Yes, sir. Done, sir. At last, this is the latest one, which is nanotechnology. The medications are piggybacked onto various nanoparticles, which bypass the biological barriers, rendering the drug delivery directly to the target sites. And these are the nanoparticles. Thank you.
I thank Dr. Shailaja as usually for rocking her talk.
Thank you, ma'am.
I request Dr. Kumar Amrut to come and deliver his talk on innovations in glaucoma drug delivery. Is it the end of eye drops?
Good morning, all. Thank you, APOS.
Kumar, please stick to the time, no?
Sure.
Because the
Sure.
other people will come next session.
First of all, I want to thank APOS and AIOS for this opportunity. So I'll be talking on the innovations in glaucoma drug delivery. I think Madam has already covered few of the slides. So as we all know, glaucoma is the leading cause for irreversible blindness, and so the primary risk factor is the high intraocular pressure. So it is also the only risk factor that is modifiable. So the therapeutic approaches at present available are one are the topical hypotensive medications, laser therapy, and the surgical therapy. So medical therapy is the first line of therapy. So it is simple, safe, and also effective. Generally, we start with a single medication. So as to reach the target pressure, we keep on adding the medications. So topical therapy has got many limitations. So two main limitations. One is the non-compliance, other one is the effectiveness of the therapy. So there are different reasons for this non-compliance. So one could be the elderly age group, and the cost factor is one of the important limitation. Then forgetfulness of the eye drops, and the side effects, both the ocular and the systemic side effects of the topical therapy. And the other thing is the efficacy of this topical therapy. So once you install the eye drop, so less than 5% of the medication reaches the target tissue. So 90% gets into the systemic absorption. So there are many reasons for this lesser bioavailability of these topical medications. One, it could be due to very short contact period with the cornea, so rapid turnover and drainage through the nasolacrimal duct. So we can see only, say, the other thing is the size of the topical eye drop, so which is around 30 to 40 microliter, whereas the size of the conjunctival cul-de-sac is hardly 7 microliters. So more than 90% of the drug wastage is also much higher with the topical therapy. So the other issues with the topical therapy is, one is the ocular surface disease, and so there is a need for ideal drug delivery because of the limitations that we have with the topical therapy. So what should be an ideal drug delivery? So it should deliver the drug at a constant rate. It should have a more contact period. The bioavailability of the drug should be on the higher side with minimal side effects. So there are different techniques. So there are, I have mentioned only a few: the inserts, contact lenses, punctal plugs, nanotherapy. So these are broadly classified into two: the extraocular devices and the intraocular devices. So we'll just go through only a few of these implants. So one is the gel forming drops. So what this is, these are actually a liquid forms, but once they come in contact with the tear film, they convert into a gel-like structure, and they stay there in the cul-de-sac for over a period of month, and slowly the drug being eluted onto the ocular surface. Then we have the inserts. So these are devices which increases the contact time of the drug with the ocular surface, thereby increases the bioavailability. So some of these ocular inserts are already being discussed by Madam, say the pilocarpine inserts, OcuSert. Then we have the collagen shield, which is placed on the cornea, which is a small disc. Then you have the mini disc, which is placed under the upper eyelid. So all these ocular inserts stay there in and around the eye, slowly eluting the drug onto the ocular surface, increases the contact period of the drug to the ocular surface, and increases the bioavailability. These can last up to few weeks to months. Then the biometoprost ocular insert, I think already discussed. So this is a ring shape placed in the fornix. So it stays there for few months and slowly eluting the drug. So then you have this TOD, the topical ophthalmic drug delivery. So it is like a contact lens made up of hydrogel placed under the upper conjunctival fornix, contact lenses. Then we have the punctal plugs, the ocular therapeutics. So these also, say the punctal plugs slowly elute the drug onto the tear film, and these can stay up to 3 to 6 months. Then you have some subconjunctival inserts are there. So these are very small, the size of a grain, and need to be implanted, but they need a procedure either in the OPD or in the theater. They needs to be implanted under the conjunctiva. Then you have this micro electromechanical system. So this works on the principle of electrolysis, and the rate of electrolysis will regulate the amount of the drug that is released onto the ocular surface. So this is the electromechanical pump system. So what are the issues with these extraocular implants? One, how well they will be tolerable, because these are placed in and around the eye, how well they will be tolerable. There are some side effects with these devices also, the hyperemia, the irritation, the foreign body. So again, we need to know how long these devices will deliver the drug at the right dose, the therapeutic concentration. They have to be maintained all throughout the time the implant is there. Then you have the intraocular, that is Durasta. It is the only FDA approved device at present available in the market. So it is placed into the anterior chamber, but needs a injectable injector. So usually done in the theater. So then you have this Travoprost XR. This is also placed in the anterior chamber. It is a rod-shaped implant. And then iDose, so this is a titanium with a reservoir, needs to be anchored to the trabecular meshwork, so you need an invasive procedure, so it has to be done in the theater. So with these intraocular implants, they are definitely much more tolerable than the extraocular implants because they are placed inside the eye. So unlikely to fall out. They have much longer duration of action when compared to the extraocular implants. So it easily bypasses, say there is no problem with the barriers. So as it is placed inside the eye, surface side effects also less likely when compared to extraocular implants, but the only thing is it requires a minimally invasive procedure to implant. So the advantages definitely when compared to topical therapy, there is a reduced dose frequency, so less drug wastage, no need to install the drops daily, fewer side effects when compared to topical therapy, and better diurnal IOP control when you compare to the topical therapy. Topical therapy is like pulsatile. Once you put the drop, the peak action it will be there again, it comes to plateau. But here it is a better diurnal IOP control with these devices. And finally, it ensures the adherence and compliance with the glaucoma patients, and it can improve the quality of life of them. So to conclude, definitely topical therapy has got few limitations, the most important being the adherence and the efficacy of the therapy and the side effects with the topical therapy. So there is a clear need for some sustained release devices. So many of these devices that we have discussed are in the preclinical and clinical stages of development, and the data that we have today is mostly on the animal studies and few on the human trials also, but much larger trials has to be conducted before these devices are available for clinical use in glaucoma management. But when these devices comes into use, definitely it will improve the clinical management of glaucoma, and also it will improve the patient quality of life. Thank you.
Kumar, how often you are using in your clinical practice? In your clinical practice, how often you are using this?
No, sir, we are not using. Not using any of these devices.
Only theory.
Say, only at present, only one drug is available, which is FDA approved, is Durasta. All other are still not available. Only Durasta is the only one which is approvable, and it is some centers I think are doing. Other all are still in the different stages of development, clinical trials. Okay.
Thank you, Dr. Amrut.
Thank you.
For an informative lecture on innovations in drug delivery. Hi everyone, this is Vasanta. I'll be talking about common mistakes in glaucoma management. So do we really commit mistakes? Yes, obviously. If we try to search for them, you will find a big list. So I tried to miss my mistake. I'll reveal it. So my mistake. So while dealing with this patient, I forgot to ask about the history of topiramate use in this patient. So can I say and escape to err is human and try to erase the mistake? Can I do that? It will worsen the situation. So if I start making a list, it's becoming very big. It's not even included in this list also. So sometimes we think that it's a very small mistake, but even then it can lead to big consequences like blindness. So that is irreversible, black hole of irreversible blindness. So if you will wonder if you know that it is sitting like a time bomb on us. So why to bother about our mistakes? Because it has got medico-legal implications. If we look at this data of Westlaw, about 40% of the cases involved allegations for the mismanagement of failure in diagnosing and treating the glaucoma cases. So which are more than the surgical errors. So if we see here, disproportionately high awards are being granted for the glaucoma malpractice. So which is keeping us in a peculiar situation, unique litigation. When you compare ophthal and glaucoma also, it's almost equal, keeping the glaucoma in second rank. So the objectives of this session is participants at the end of the session will be able to list out their own mistakes and errors, and also they get sensitized to the medico-legal implications. There are many types of errors that we commit either in planning, that is, we try to treat the neurophthal case with the anti-glaucoma medications, or errors in executions by omitting or committing. So error of omission means we record intraocular pressure in one visit, or we don't do 10-2 in advanced glaucomas. Error of commission means we prescribe prostaglandins in cases of uveitis and unilateral glaucomas and pregnant ladies. So is this an error of omission or commission? Doing trabeculectomy this is a question for you. Doing trabeculectomy in morning glory syndrome. Omission or commission? It is definitely a commission, no? Doing a wrong thing. Thank you. So which gets included in the glaucoma surgery settlements, where unnecessarily surgery is being done. So after reading this chapter in this book, that is Chandler and Grant's, I got an idea. That means this is a never-ending topic. We can, on last day of my breath also, I can keep on preparing my list. So this can be classified as missing the diagnosis, incorrect diagnosis, treating, over-treating, under-treating, or insufficient communication with the patient. So sometimes we miss the diagnosis by not taking proper history, like steroids and trauma. So there is a joke in a book by clinical epidemiology by Sackett, that is, a patient goes to all the doctors in the town and goes to a gastroenterologist, and he says that only one thing is left over, that is history and physical. So they are all ready with all the reports. Patient came with all the reports. So some of the points patients won't tell us, even we don't ask in the history, and we'll miss. And you'll be wondering, you'll surprised to know that even subspecialty people also, they try to forget, asking in the history about the steroid use. Finally, they will land up in steroid-induced glaucoma. So this is a public health problem, but parents and patients are also, they are not filing cases. That's why we are not looking at the steroid-sparing agents in some conditions. And we miss the history of you asking about trauma in some cases, and we forget about asking about beta blocker systemic use. And sometimes we use the slit lamp as a torchlight also and miss some of the findings. And we use surrogates also for gonioscopy and do mistakes. And sometimes we conveniently make the assumption that looking at a shallow AC, we call it as a closed chamber. Looking at a deep chamber, we call it as an open angle. But the evidence suggests that only negative predictive values can help us in these situations. And we also forget that we have got unique eyes. And we always say that POAG is more common, and we try to forget that blindness is more common with PACG. And many of the malpractice claims are related to YAG iridotomy also. And we miss the diagnosis by not using a correct tonometer to that particular condition. And we start saying that anyhow, angles are very open, Anyhow, we have to do cataract surgery, we need not bother, we can bother about glaucoma later. And we do some mistakes because of the lack of knowledge of about the corneal behavior. Sometimes we are scared of dilating also in angle closure suspects. And miss the diagnosis like diabetic retinopathy and some other important retinal condition. And we miss the difference between the color and contour also. And we forget to recognize the neurological fields in a case of glaucoma. And GRED sir was talking about red disease and green disease. So because we go by color only means, that's all. We will be in the soup. So we should never get fooled. Sometimes we misinterpret, open angle closure as open angle glaucoma. So we forget that there is a master of disguise. And even Chennai glaucoma study also revealed that we missed many angle closures. And we try to undertreat advanced glaucomas also. We'll be happy with high teens instead of going to the low teens. And I told you about 10-2 that we missed in advanced glaucomas. So once you see 21, we start treating every patient. So many suspects, we start treating them unnecessarily. That is a big mistake. And sometimes we don't treat the green disease. And most of the mistakes are related to medical. And we don't communicate also properly with the patient. And we just go by with signature is enough for us with patient's consent without even talking to them. Can we tolerate if the patient says in the court, I didn't even see the doctor until the day of surgery. So the defensive medicine model is a very wrong one that we follow even now. So on patient safety day, they have emphasized about the shared decision making model. That is, we need to elevate the voice of the patients. So finally, if we want to reduce the mistakes, you have to pay attention to the complete examination, documentation and counseling. Sometimes patients don't use drugs, no, they are not complained. That also has to be documented. Comprehensive examination means, I remember only Professor Ravi Thomas always, not like this, sometimes we try to do like this, I know. So not only the patients suffer with the glaucoma, even we have to suffer if we don't take care of our mistakes and try to jump and fix it. Even in the clinical audits also, we pay attention to the individuals instead of the errors. So let us pay attention to the error-prone systems and try to understand that even a single mistake will make a lasting impact on the quality of the life of the patient. Thank you.
Thanks Santa, for your nice talk. Next.
So I request Dr. Venkatratham sir to deliver his talk on what is important in glaucoma other than intraocular pressures.
Welcome, Dr. Venkatratham garu.
Thank you, sir.
You learn from him. He is the most experienced and highly.
No, sir.
famous
Before we
glaucoma.
are all kids, sir. We are all kids before you, our experience. So I thank profusely the AIOS organizing committee of APSOS and dignitaries sitting on the dais and my dear friends. So this is not the presentation. No, it is not here. It is pasted already. No, here only. I gave it to you. Thank you. So we all concentrate, once it is a glaucoma, we all concentrate from the our main post-graduation itself. We think about only intraocular pressure is glaucoma. Glaucoma is intraocular pressure, that's all. Beyond that, we don't think anything else. Now, this is our understanding. Intraocular pressure, nothing but, glaucoma is nothing but intraocular pressure. And another is, now our thought process is changing to intraocular pressure to optic nerve sensitivity and optic nerve ischemia. Now the present day, the major thought process is going towards the optic nerve ischemia and intraocular pressure as well as optic nerve sensitivity. In spite of knowing all these things, we have certain gray area there. This gray area is persisting since a very long time. Till now, we are not able to crack into that gray area to find out what is the pathology of glaucoma. Now, this is the reason why we want to see what else can cause glaucoma, what else can contribute for the loss. That is the reason why we are going for this presentation. This is the load. Even till today, even in the Monday OPDs in Sarojini Devi Hospital, it is overcrowded. The everlasting increase in the glaucoma prevalence in the society. Right. Intraocular pressure is undoubtedly modifiable risk factor. Still, we have certain other goals when we are approaching a patient. Protect, restoration is, I don't know, it is a questionable. Reduction of intraocular pressure is the main aim. And monitor the rate of glaucoma progression. As already ERD sir told us how to see that and determine the other risk factors what are contributing for the glaucomatous loss. This is the one landmark study saying us that 28% of the patients, it has seen in 167 patients in a multicenter study, saying that 28% of the patients progressed further in spite of being intraocular pressure is maintained at 17. 43% progressed when the pressure is 18 and 19. When 70% of the people are progressed when IOP is maintained at 20. That means intraocular pressure is not always contributing for the total inhibition of the ganglion cell loss. So, though the intraocular pressure is very important, we should concentrate and see other things where the patient is progressing beyond the intraocular pressure. We know the landmark studies about VOTS and EMGT, AGIS and corroborative normal tension glaucoma studies. All this says that low perfusion is a significantly a risk factor. At the same time, age is very much significant risk factor. We know that the population percentage of people who are crossing more than 60, it increases, automatically prevalence of glaucoma increases. There is no doubt about it. CCT is another contributory risk factor, and CD ratio, we are giving more importance to the CD ratios, but it is very less. And PSD is also, we are giving importance, but it is also contributing very lesser. And hemorrhage and the disc hemorrhages are very significant risk factor for the glaucoma progress as well as for the diagnosis. So corneal thickness we know all, because the higher thickness will overestimate the intraocular pressure and lower thickness will underestimate the intraocular pressure. We should not get biased by that. The risk is misread by the eye pressure. Suppose you see only intraocular pressure basing on to diagnose the glaucoma, if the thick cornea and if the thin cornea, it is very dangerous. Suppose the intraocular pressure is low when you are recording in a thin cornea, but the original intraocular pressure is more. So that is very dangerous to the patient's progression. And thick cornea is otherwise a safe area. Suppose if there is a thick cornea and you are measuring high and actually there is no glaucoma, unless you check for the intraocular, check for the central corneal thickness. This is the nomogram we are all following, like Ehler's formula. 70 microns change in the baseline are the mean CCT from 555, and 70 microns will change 5 millimeters of GAT intraocular pressure. So either side, this side or that side. If it is less, we need to add. If it is more, we need to subtract. And another important risk factor is DOPP, diastolic ocular perfusion pressure. We don't care about it usually in the clinical scenarios, but it is very important. Once the diastolic blood pressure is 80, minus 16, what is the Gaussian mean of the intraocular pressure? You remove it, it will come under 64. If this reading comes down to the less than 55, it is a very important progressive indicator for the glaucoma. Evaluating the CD ratio, we are all give more importance to this. The single, if you take only CD ratios as it is, unless we are comparing with the overall disc size, then we are making a mistake. There is no doubt about it. Because the bigger disc will have a big cup, the smaller disc will have a smaller cup. So, whenever you are seeing a big cup with a big disc in a big cup, we need to think and compare with it to the disc size, location of the disc thinning, changes in the vasculature, and color changes are very important. We ignore it. Usually a sectorial color change is significant for the glaucoma diagnosis. Please remember this. Disc hemorrhages are very significant. Disc hemorrhages in a patient with glaucoma are most frequently observed inferiorly, along with PPCRA and nerve fiber layer defects and field change correspondingly. So, it is also very important. And optic nerve head observation for the presence of the disc hemorrhage is an important biomarker for the glaucoma damage. So, myopia, we know this is myopia, as already sir told it, this myopia will always confuse, and Vasanta madam already told that treating the morning glory syndrome, thinking that it is glaucoma. I have seen several cases like that, treating unnecessarily. This requires only longitudinal observation. You cannot decide with a single examination with the myopia and glaucoma. This is very confusing. Unless you follow the case further and document it properly, then at one point you know that this is only pure myopia or glaucoma. Otherwise, you can't decide on the single examination. So, cerebrospinal fluid pressure, of course, reading is very difficult, and modifiability is a questionability. That you have patients with open angle glaucoma and normal tension glaucoma have a lower CSF pressure, whereas patients with OHT have a higher CSF pressure than controls. So, CSF pressure is also important. The damage occurs at the level of the lamina cribrosa. We are measuring the transcorneal intraocular pressure only, because the movement of the lamina cribrosa, because of the variation in the pressure gradient between the intraocular and the cerebrospinal fluid, will make the damage. And obstructive sleep apnea. We are all forget this. Obstructive sleep apnea is a major risk factor for the developing of glaucoma. Studies show that strong association between the obstructive sleep apnea and glaucoma. Complete ophthalmic evaluation should be advised to every follow-up for these patients. Glaucoma patients with obesity and progressive visual field damage, even under the low eye pressure, should be evaluated for the obstructive sleep apnea, and because the sleep labs are available in Hyderabad. 10% of the obstructive sleep apnea sufferers have glaucoma. No doubt, 50% of the normal pressure glaucoma patients will have obstructive sleep apneas. So, corneal biomechanics are another important risk factor. This evidence suggests that eyes with a thin, stiff corneas are higher risk of developing glaucoma. Though the ocular response analyzer we are not using at all to measure the corneal this thing, pliability of this, and in the future, I think that it will come into the protocol in the evaluation of the glaucoma. Right. Other confusing conditions with normal intraocular pressure is, so though it is, sir? Yes, sir, finishing. Other things are important is multiple sclerosis, Parkinsonism, Alzheimer's disease, we are all forget about this, and toxic amblyopias like tobacco, ethyl alcohol, thiamine deficiency, ethambutol, drugs, there are several other drugs, but ethambutol and INH are important. Vascular, AION and PAON, these are all confused the glaucoma. They are all looks like glaucoma, but it is not glaucoma because we need to think about all these things. At the end, glaucoma is perhaps more multifaceted than the less understood than all other eye conditions, given the ocular, vascular and neurological involvement. Much confusion stems from the glaucoma being a neurodegenerative disease now. Having vascular etiology, yet only IOP being commonly discussed and treated. One final caution is, any patient you are seeing with the progression of glaucoma and intraocular pressure is maintained always and diurnal normal. Never think that all these factors which may be contributing for the loss of ganglion cell. Thank you, sir.
Thank you so much, Dr. Venkatatnam, sir, for nice pics and pie diagrams in the first slide itself, and very nicely mentioned about RCTs also. Now I request Dr. KVV Sachinarayan, sir, to deliver his talk on perspective of angle closure glaucoma.
Good morning. Good morning to the chairpersons and my friends. Today my talk on perspective of the angle closure glaucoma. So no financial interest. So PACD is a dangerous variant of glaucoma. So primary angle closure disease, that includes about the primary angle closure suspect, primary angle closure and primary angle closure glaucoma along with the acute angle closure glaucoma. These clinical findings are shallow AC with raised IOP because of the pupillary block or arteriotrabecular contact, with leads to the ultimate blindness if it's not treated in time. Paul Foster in 8th World Glaucoma Congress cautioned that Asia harbors the highest percentage of the primary angle closure disease. So prevalence of this PACD is becoming on the rise because of the increased number of centenarians, because of the increasing life expectancy, because of the improved health facilities. So incidence of angle closure glaucoma in Asia is 40 times higher than among the Caucasians. We have to think about this point. And the prevalence of PACD is also rise in the West. West, they are supposed to think that POAC is more common in the West, but recent trends in the last 10 decades, in the decade that they are telling that PACD is on the rise in the West also. This is the incidence of acute angle closure glaucoma in emergency department of the US, and PACD is more common in the West now, including UK and Italy. When it comes to the Indian scenario, the PACD incidence is almost 50-50 in some parts of the north and including the PGI, West Bengal study and the Shankar Nethralaya. But prevalence of glaucoma in the North Coastal Andhra, we have conducted a study from Regional Eye Hospital of Visakhapatnam. Our conclusions are POAC is 43.6% and PACD is 24% around. And there is a disproportionate burden of blindness because of the PACD. And PACD blindness is 3 times higher than the open angle glaucoma. And blindness in the India because of the PACD is on the rise. About it harbors about 1.5 million blind people are in India are blind because of the glaucoma, mostly because of the angle closure suspects. And there is one paper recently from RP Center stating that the rapidly emerging non-communicable ocular disease in India because of the glaucoma blindness. And when it comes to the pathology, mechanism, that the Curran, who is the father of angle closure glaucoma, proposed this relative pupillary block theory in 1920 itself. And later the World Glaucoma Association proposed some other mechanisms of the ciliary body, lens, causes behind the posterior segment and lens also. So we can predict by simple tests to pick up the angle closure glaucomas by seeing the pattern of the iris. Less number of furrows, it is an indication of angle closure suspect. And also when the iris dilates, there should be a disproportionate loss of the iris volume. This equation will be lost in angle closure glaucoma. And PECD is more common in Chinese. Why it's more common in Chinese? Because most of the studies says that anterior insertion of the iris is more common in the Chinese, and also thick peripheral iris. And the Chinese iris is more sticky. It's more prone for the angle closure diseases and the PSC formation. And if you look into the retinal arterioles, angle closure glaucoma has the narrowest angle closure when compared to the open angle glaucoma. And the decay of the RNFL is more rapid and acute in angle closure glaucoma when compared to the open angle glaucoma. So there is a classification fostered in 2003 by ISJO, classified into PSCS, PAC and PSCG, which is useful for the diagnosis and management point of view. And there is another classification, pre-glaucoma and glaucoma stage, where it includes the acute stage of glaucoma in open angle and glaucoma stage. And progression, it leads to 73% of chronic PSCs are without any symptoms. This is the most stressor point we have to think it of. Acute angle closure glaucoma, as you know, the family history plays a most significant role. These are all the risk factors, you know, but genetic predisposition is most common. Age is the definite risk factor both for the open angle glaucoma as well as the narrow angle glaucoma. And the lens thickness is a major risk factor. As the age advances, the thickness also of the lens is also increased. Myopia is not an exemption. Where we have to stress more at this point, there are studies shows that about 2 to 11% of the cases of myopes, they are having the angle closure attacks. So ethnicity, especially in Japan, they are more prone for two types of glaucomas, angle closure as well as the normal tension glaucoma. And this angle closure glaucoma is more proportionate and more in the low socioeconomic group. And as you say that glaucoma is the pattern of investigation. Start with a simple torchlight flashlight test. And as Dr. G.V. Reddy says, the gonioscopy is mandatory. I stress more upon the gonioscopy. Do gonioscopy, repeat on the second day, third day, till you confident about the angle configuration. So gonioscopy is mandatory, which shows these narrow angles, occludable angles, closed angles, as well as with peripheral antisynechia. So some cases, chronic headaches, they are being treated with the neurophysicians, thinking that it is a case of migraine. But after 10 years, these cases has been referred to the ophthalmologist. By doing the simple gonioscopic examination, they labeled it as a primary angle closure glaucoma. This is already late. And there are automatic this thing as management, as you all know, that laser peripheral iridotomy, it reduces the incidence of angle closure glaucoma in the west as well as in the east. Eagle study shows the clear lens extraction, deepens the anterior chamber, and don't neglect the fellow eye. This is because 40 to 80% of these cases are prone for that. And awareness, creating awareness regarding the angle closure glaucoma is a must. Take home message, PAC, these are the roads for the blindness, permanent blindness. Simple 5 minutes examination of the salvashi with gonioscopic that can prevent the permanent blindness. Female, don't neglect a female of 50 years with hyperopia. Think about the incidence of PACD. Don't ignore the family history. Flashlight test. You don't need any sophisticated instruments. If you have the think in mind that simple flashlight examination, you can pick up a shallow AC. Gonioscopy is mandatory, and LPA, simple treatment, is very effective, can prevent from the blindness. Don't wait for the symptoms to develop, because symptoms rarely, 75%, they don't have any symptoms. And put pilocarpine if LPA laser facilities are not available. Incomplete PID is very dangerous because it produces aseptic uveitis. It leads to peripheral antisynechia. Finally, it lands up in the PSCG. And regular follow-up in spite of patent PA is also essential. PSCG blindness is avoidable if you pick up this case at an early stage. Thank you.
Thank you so much, sir, Sachinarayan sir, for giving a nice talk. Somehow I missed one point in the slide. POEG is called as a giant and PSCG is called as a, something you have mentioned in the slides. So POEG as a giant and PSCG as a, you have mentioned somewhere as POEG is a giant And PACG is
PS is a big giant more than
It's
the
a big
POS.
giant. I thought it will be
Yeah.
zombie. Okay, thank you so much, sir. It was nice. Now I request Dr. Malleshwari to deliver her talk on steroid-induced glaucoma, the extent it goes.
Good morning, one and all. So, steroid-induced glaucoma we all encounter in our day-to-day life. So, first of all, thanks to APOS and thanks to GRD sir for giving us this opportunity. And this steroid-induced glaucoma, like we all do cataract surgery and we need to keep steroids for 4 to 6 weeks depending on the cataract. And so, we all encounter this steroid-induced glaucoma. So, the steroid responsiveness we can see in almost all patients. Sometimes it will be around less than 6 millimeters of mercury, sometimes it will be between 6 to 15 millimeters of mercury, sometimes it is more than 50 millimeters of mercury from the baseline. So, most of the patients they used to have this low responsiveness, and some patients they used to have this moderate responsiveness, that is between 6 to 50 millimeters of mercury. So these patients, they are not having much problem, just giving anti-glaucoma medications is fine. And the next group is the high responders, where the intraocular pressure is more than 15 mm Hg from the baseline, or it may be more than 32 millimeters of mercury. So these patients usually encounter problems, they need medical therapy, they need surgical therapy. So all these patients, so they do need therapy in case of high responders. And when it will happen acutely or it will happen in weeks to months period. So if acute phase we will encounter in case of depot steroids like intravitreal triamcinolone, or if the patient is on high potent topical as well as systemic steroids. But the most commonly we used to see after 3 weeks or after 4 weeks of taking steroid therapy. So which age groups are affected? So all age groups are affected, but most commonly the children less than 6 years or the older folks are more commonly affected. And the presentation is most of the times it's asymptomatic, and sometimes if the patient pressure goes to 40 or 50, when the corneal edema develops, they used to feel of blurring of vision. So always the prevention is better than cure. So always the physician should aware that the patient underlying conditions and then counsel the patients. And if the patient is a child, you need to counsel the parents very thoroughly. And before starting any steroid treatment, the physician should take a call to counsel the patient and should take the history of all these things like primary open angle glaucoma in the family, or younger children, or high myopia, or uncontrolled diabetes or hypertension, rheumatoid arthritis, or previous history of steroid responsiveness, or Fuchs disease. These things we need to take into consideration before starting steroid. So once the patient develops steroid responsiveness, first thing is we need to stop the steroid. If we can't able to stop the steroid, at least we need to come down to the low dose therapy, and then you need to start the glaucoma management with the medical management. Then if it is not controlled, you can go for surgical treatment. But if the intraocular pressure is not reduced even with the medical management, if it is a depot steroid like intravitreal, you need to excise that one by doing vitrectomy. And the steroid, like I already said, if it is definitely needs steroid, you need to come down to the low dose steroid. And if it is less than 30 millimeters of mercury, there is no glaucomatous damage, simple discontinuation of the drug is enough. If it is more than 30 millimeters of mercury with mild to moderate damage, you need to stop the steroid first and then continue with the anti-glaucoma medication for 3 to 6 weeks, then assess the patient and then you can reduce or you can add the medication. If it is more than 20 millimeters of mercury with the maximum medical therapy, and if it is advanced glaucoma, definitely you need a surgical treatment. So I'll show 3 of my cases. This is a first case of 45-year-old female, came with vision of CF 1 meter in left eye, 46 millimeters of mercury of IOP, and she had 3 months history of post-cataract surgery. She is using Aflox D 4 times daily after 1 week. First week she used to use 6 times, and the next 10 weeks she was on Aflox D 4 times a day. So the pressure rose to 46 and hazy fundus. Just we had 1 carbonic anhydrase inhibitor, systemic tablet Dimox OD for 1 week and stopped steroids, and at the end of 2 weeks the pressure is 16 and vision is 6.6, fundus normal. So just discontinuation and a short course of oral steroids is oral carbonic anhydrase inhibitor is enough. And the second case is a young boy of 8 years we saw in 2017, and vision in right eye 6.12, left eye 6.9, severe VKC, and the consulted some local ophthalmologist, they gave steroids, and they got some relief with the steroids, so the parents brought the medication, on-counter medication, and they are using in between. Finally, he developed steroid-induced glaucoma. And right eye pressure 56, left eye 48, and kept them on MMT and asked them to come for follow-up after 2 weeks. But they lost follow-up and they came after 6 months, and they developed severe VKC at that time, and they stopped AGM also after 1 month of using the anti-glaucoma medication. Now the pressure is 64 in right eye, vision came down from 612 to CF half meter, and left eye pressure is 58 and 69 is the vision. So right eye total GOA, left eye advanced glaucoma with pale disc. So we kept him on MMT. Already he lost 1 eye. We did TRAB in left eye in 2018. So this is the disc of the left eye, pale disc, and the vision is maintaining, 69 vision is maintaining in left eye since 2018. Now the patient is stable and visual field is also stable. But I feel very sorry for this young boy because he has so much of life. And the third case is a 12-year-old boy. Actually, he underwent cataract surgery in 2015 for steroid-induced cataract. And right eye now he is having 32 pressure and left eye 12 pressure. Vision is 618 in right eye and 612. He has severe VKC and fundus is 0.7 in right eye. And with the various combinations of medical therapy, after 3 months the pressure came down to 24. But he developed severe allergy to the AGM. So we planned for TRAB in 2020, December 2020. So TRAB was very well worked for 1 year, and after 1 year he developed another severe episode of VKC where he kept on high dose steroid. Again the pressure rose to 46. After 3 months of medical therapy it was not coming down. Again we did second RAB, and that second RAB failed in 3 months, and we did bleb needling. Again that was also failed in 2 months. So finally we opted for implant. So I did implant in Jan 2023. So after implant, the pressure is maintaining around 10 since these last 8 months. And the patient, this is the optic disc of the patient. And this is the OCT picture of the patient in 2021, which is maintaining till now. And RNFL is stable. And the visual fields are stable. And finally, we could save the vision because of the good compliance and proper follow-up. And the patient mother is very helpful for following this patient. And if you find any patient like this, if they need steroids, the newer molecules like loteprednol is very useful in reducing the IOP spikes. And this is the resume we need to follow for all patients who are on steroids when they have steroid responsiveness. So for every 2 weeks you need to follow, and you need to assess the pressure, and if there is any pressure rise you need to start the treatment. And in future maybe anti-steroids may come, but all are in the experimental stage. The take-home message is steroid is always a double-edged sword. Always assess the risk factor before starting steroid treatment in any patient, especially those who are on chronic uveitis where you need recurrent use of steroid, and in VKC patients, and check for responsiveness in those patients for every 2 weeks. And always the prevention is better than cure, so always assess the risk factors, and early detection and proper treatment will always key to the success in these steroid-induced glaucoma patients. Thank you one and all for giving me this opportunity.
Thank you, doctor. So systemic steroids usually they won't cause a much rise of IOP, sir.
Most of the times it's the topical steroids or the intravitreal steroids or the steroids which are applied onto the skin nearer to the local area, nearer to the eyelids or systemic steroids. If you use for long term, even the renal patients where they underwent renal surgeries, they used to have steroid induced cataract, but glaucoma we found it's less when compared to the topical and the intravitreal formulations.
Thank you, Dr. Malishwari, for a nice talk with interesting case scenarios.
Thank you, one and all.
This session is over. I request the organizing team of the next session to take over.
Thank you all the speakers and the audience. Now the session comes to an end. Thank you.